Welcome everyone to Using Mindfulness and Acceptance-Based Approaches for Insomnia with Jason Ong, PhD. I look so forward to sharing more about Dr. Ong's background and introduce him to you a few minutes from now. So I am Ed Glauser, your host for Dr. Ong's webinar, and thanks to so many of our participants for joining us on the webinar from all over the world. So before we get started, I want to introduce you to Heather Butts with Learn for Life Consulting, LLC, and our producer who will go over the technical aspects of our webinar experience. So welcome, Heather.
Thank you so much, Ed. So first, if you are watching this webinar video on YouTube as a recording, please advance the webinar to the disclaimer slide. If you are joining the slide, please listen to the following instructions. It is my pleasure to help you with any technical issues that may arise for you during our live webinar. First, you can either listen to the webinar from your computer by clicking Listen Only in the audio options area of your control panel, or call the meeting burner phone number at 949-202-4265 and enter the PIN number of 767-6870#. Also listed in the audio options area of the control panel. It is highly recommended that you use the phone line in case we have any technical issues on the meeting burner platform. Also, you will now need to find the down arrows next to the host and audio options areas of your control panel and click on those down areas to expand the chat area you will be using for the rest of the webinar should you have any technical questions throughout the webinar and for topic-related questions and comments after Dr. Ong concludes his presentation. If your question has not been answered at the end of the presentation, you can email us at info@mindbodymedicinenetwork.com and Dr. Ong will get back to you with your answer. And now, I would like to turn it back over to Ed Glauser, the owner and principal clinician with the Mind Body Medicine Network and our host for Dr. Ong's webinar. Thank you.
Thank you so much, Heather. And Heather Butts will be responding to any of your technical questions in the chat area. So please ask in the chat area instead of the Ask a Question icon on the Meeting Burner platform. So please see our website for more information on all of our offerings, including our webinars, webinar recordings, and online trainings. So this webinar is educational in nature and is not medical advice. It is not used to diagnose, treat, or cure any health disorder. Please consult with your healthcare provider whenever your health is in question or if you have a desire to make any changes related to your current treatment. This webinar can be used in conjunction with your current healthcare provider's approach in treating any of your health-related conditions. And now, the Mind Body Medicine Network presents Using Mindfulness and Acceptance-Based Approaches for Insomnia with Jason Ong, PhD. So I'd like to share a little bit about Dr. Ong's biography. Dr. Ong is a licensed clinical psychologist and certified in behavioral sleep medicine. He is currently an assistant professor of behavioral sciences and the director of the behavioral sleep medicine program at Rush University Medical Center. His research and clinical interests involve behavioral and non-drug treatments for insomnia and other sleep disorders. He has led an NIH-funded study to develop and test mindfulness-based therapy for insomnia, MBTI, and has published several papers on mindfulness and health. So I'd like to welcome Dr. Ong. Thank you so much for joining us.
And thank you, Ed, and good evening, everyone, or it looks like it might be good afternoon or good morning to some of you, as it looks like we have people from all over the place joining us. It's a snowy evening here in Chicago, so hopefully it's warmer wherever you're at. It's an honor and a privilege to be able to share with you guys some of the things we've been working on in this area with mindfulness and acceptance-based approaches for insomnia. And just wanted to start off by giving you an overview on what we'll be doing today. So our learning objectives are, first of all, we'll be describing the theoretical underpinnings of mindfulness meditation and the application to insomnia. So explaining some of the conceptual frameworks for this area. And then we'll explain the components of mindfulness-based therapy for insomnia. This is an intervention we've been developing that uses mindfulness-based approaches for people with insomnia. And we'll also provide some examples of empirical support for mindfulness-based therapies for insomnia, both in terms of some of the work that we've been doing and also work from other groups. So I work in a sleep disorders clinic, and first I wanted to just give you a sense of the type of patients that I usually see on a typical clinic day. As you can see here, this is a good example of the first patient, and I'm calling it a hard day's night. So this is somebody who comes in and is complaining that during the daytime, when he wants to be thinking, wants to be alert and awake, he's dozing off or he's not able to get his work done. And then at night, when he wants his brain to shut off, it's not shutting off. And so it has there, don't think, and he's got all sorts of thoughts running through his head. So the idea behind this is that insomnia is a 24-hour problem. It's not just a problem at night. It also affects you during the day. There's daytime consequences. So that's how we really conceptualize insomnia now. Next slide. So the second patient that I might see is somebody that I'm calling may the force be with you. So as you can see here, this is somebody who's really determined to go to sleep. And if you can even see the expression on his face, he's gritting his teeth. He's just really trying very hard to sleep. And so sleep is one of these things, if any of you have experienced insomnia, the harder you try, the less likely you are to fall asleep. But this is very representative of people with insomnia who are really putting in a lot of effort for sleep to happen. Next slide, please. So this third patient, I'm calling the thinker. Okay, so he gets into bed, and about 1 o'clock, he has his eyes on the clock and is thinking, all right, great, if I fall asleep now, I'll get 6 hours of sleep, everything will be okay. Well, then a couple hours goes by, and then he's starting to get a little bit more distressed. He's got one eye on the clock, and he's thinking to himself, if I fall asleep now, I'll get 4 hours of sleep and drink lots of coffee. So now he's starting to think about how he can compensate for not sleeping very well. Well, a couple hours goes by later, and then he's now quite distressed. You can see the look on his face. He's even grabbing onto his pillow there, and he's thinking, if I wake up now, I can call in sick before anyone even gets to the office. So he's thinking about ways to compensate, ways to try to avoid any kind of conflict or embarrassment, and is really kind of caught up. And so this guy, the thinker, is really wrapped up in this problem of insomnia, and it's really, if you think about how much effort and thought he's putting into this and all the different things that are running on in his mind, it's no wonder why he can't sleep. Next slide, please. Okay, so we've seen a few patients here. I wanted to come back to, what, if we could kind of summarize this, what a model of chronic insomnia might look like. So oftentimes there's a triggering event, and this might be something that's stressful. For some people, it might be losing their job. Maybe it's stress from work, having deadlines. For other people, it might be a medical condition, medical illness, for example, staying in the hospital. Sometimes it's even traveling across different time zones. So the idea is that something usually starts and triggers the sleep disturbance. And then the sleep disturbance, as we've seen, starts with what happens at night. But then it starts to go into daytime consequences. So now it's starting to have an interaction here between what happens at night and what happens during the day. And then on top of that, you get the third component here, which are the reactions. Okay, so, and you can see from the people we've looked at, the 3 patients, several of them are having reactions to not sleeping. And then after a while, it becomes bidirectional, where people are having reactions to their sleep disturbance and their daytime consequences. And then what happens is that this hyperarousal starts to form. Okay, and you can see here in the middle that as these things start to interact, people get very anxious about sleep, and then it starts to grow. And so try to demonstrate this. Oops, it looks like it exploded there. If we can just go back one there, Ed. All right, so just to kind of finish the point here, as this thing kind of gets really big here, I tried to show how hyperarousal kind of takes up the whole territory or whole domain here. So now the sleep disturbance, the daytime consequences, the reaction, it's all kind of mixing together, and people with insomnia usually have higher levels of arousal or anxiety than people who don't have insomnia in relation to their sleep. Okay, now let's go ahead and move on. So what I wanted to show you here is a model that we've been working on. So you saw that we started off with hyperarousal, and what we've done is actually split that hyperarousal into a couple of different areas. Okay, so this is primary arousal, and as you can see, some of the things popping up here that relate to primary arousal are the thoughts about sleep and the cognitions about sleep. So these are expectations about sleep. So some people feel that you might need to sleep 8 hours a night, the consequences of sleep loss, and then also increased mental activity in bed. So we've seen this in some of the patients here. Now what we're saying is that that's a primary level of arousal. There's also a secondary arousal. And some of the things that go into secondary arousal, you see them popping up here. These are things that aren't exactly thoughts themselves, but really they are what I would call a metacognitive level, in that they are how we relate to those thoughts. So we have here absorption. People who have insomnia tend to be very absorbed in their sleep problem. In fact, for some people, it becomes their identity. I've heard of people saying that they are known as the insomniac in the office, or the family member who just can't sleep well. So they're very absorbed in the problem. And then a lot of times there's a lot of rigidity. People are very focused on a particular routine that they need to do in order to sleep well. And there's a lot of attachment. So the attachment to needing 8 hours of sleep or needing to be in bed by a certain time. And a lot of this leads to bias in terms of the importance of sleep in their everyday activities. So we're calling this the metacognitive model of insomnia. We've actually published this in the journal. It's called Behavior Research and Therapy, published in 2012. And so, for this, what we're saying is that there might be not just a cognitive level, but a metacognitive level that kind of supersedes that. Okay, next slide, please. So if you think about this idea of metacognitions and some of the things we've looked at there, then the next thought is, well, is there an intervention or a treatment that could come in and target the hyperarousal, these different metacognitive components? And so I have this cartoon here because where we started looking was actually something that comes from Buddhism. So I like this cartoon because it shows that someone that comes in is looking for a vacuum cleaner, doesn't have attachments. And one of the main principles in Buddhism is that our suffering comes from our attachment to outcomes. Okay, so next slide, please. So where we started looking is with meditation, and here you can see meditation has made its way to this high-impact journal in the secular world of Time, and this is, I think, actually Heather Graham that is meditating here. But the idea is that meditation has really grown from just something that seems kind of esoteric and very Eastern to something that's becoming quite popular here in the Western world. And so we've taken a look at meditation as a way to intervene with people with insomnia. Next slide. So in particular, we're very interested in mindfulness meditation. And some of you are probably familiar with mindfulness meditation, but just to make sure we're on the same page here, I think this is a common definition of mindfulness that is one that John Kabat-Zinn uses a lot, but he defines it as bringing attention to the present moment experience in a non-judgmental manner. So really, as the word implies, it's about being mindful of what is happening in the present moment and just allowing each moment to unfold as it happens. So by extension, then, mindfulness meditation is the practice of mindful awareness, or what the Buddhists would call an awakening, and it's to do so without attachment to outcomes. So again, going back to what we've seen with in the cartoon and with some of the other patients, the idea is, can we find a way to detach from our outcomes? Now, the use of mindfulness as an intervention isn't anything new, and there have been other people who have proposed these theories of the fact that this is a metacognitive therapy. So the focus here is a shift in the mental process and not so much in the mental contents, which in more traditional forms of cognitive therapy is what they tend to do. So it's different and distinct from regular cognitive therapy in that way. And other people here have called it different things. Shauna Shapiro has a model calling it reperceiving. John Teasdale and his group, they call it decentering in terms of how it helps people with depression. And others have called it positive reappraisal in terms of reappraisal for stress. And then, as we mentioned, we've talked about it in terms of secondary arousal for insomnia. Next slide, please. So there are a couple of more popular programs for mindfulness-based therapy. So many of you are probably familiar with the one that John Kabat-Zinn has developed called mindfulness-based stress reduction. MBSR is the acronym it tends to go by. And it was really made popular by the book Full Catastrophe Living. Now, MBSR itself is a general program that's really intended for a heterogeneous audience of people just with a lot of different stress conditions, pain conditions, medical illnesses, psychiatric illness. So it wasn't actually specific. And the book here on the right is on mindfulness-based cognitive therapy for depression. And this was developed by Zindel Siegel and his colleagues, where they took the basic principles and program of MBSR as a platform and basically repurposed it to make it more specific for people with depression. So these are probably the two most common mindfulness-based therapies out there right now. Now, there is other research on mindfulness-based therapies in sleep, and here I just highlighted a few that are out there. So there's been a lot of work using MBSR for people with cancer. As I'm sure you know, people with cancer, especially people who are going through chemotherapy, have a lot of problems with sleep disturbances. So this first study by Shauna Shapiro found that women with breast cancer and have more mindfulness practice reported improved sleep quality. This is after they took people through an 8-week course of MBSR. And another study by Linda Carlson and Sheila Garland found that people who have gone through MBSR show a reduction in sleep disturbance, fatigue, and stress. So not just nighttime, but also daytime fatigue, and also improvements in sleep quality and mood. And then I should note that Sheila Garland actually has a new study where they've looked at MBSR compared to CBT for insomnia, and actually found that it works just about as well. Now, a couple studies looking at MBCT, so this is a mindfulness-based cognitive therapy that they've used for people with insomnia. So one study found that there were improved ratings on the Pittsburgh Sleep Quality Index for patients with anxiety. These included people who had generalized anxiety disorder as well as panic disorder, as well as insomnia. So again, promising evidence there. And then another study found evidence for changes in sleep parameters here, increased total sleep time, decreased sleep onset latency, and also decreased worry and sleep-related cognitions. So again, some targets there in the cognitive domain. Now, these are some studies. There are other studies. So these don't have, control conditions. And they don't have objective data. There are a couple of other studies, one by Cindy Gross and some others by Willoughby Britton, where they do have randomization and control conditions. And so there is some other evidence out there. So I just want to give you a sense of some of the available evidence. Next slide, please. So one of the things we've been working on is developing what we call MBTI, which stands for Mindfulness-Based Therapy for Insomnia. And just to give you a sense of where we started with all this, we were very interested in trying to find something that could target pre-sleep arousal. And in one of our early studies, we found that a recurrence of insomnia following treatment is more likely in people who had higher levels of pre-sleep arousal at the end of treatment. So what this means is that if after going through treatment, your level of sleep arousal was still relatively high, you had a greater chance of having a recurrence of insomnia following treatment. So in 2008, we published a treatment development study. So what we did was we tried to follow different stages of treatment development, and this was really our first attempt. The aim of this was really just to see if we build it, will they come, to see if it's feasible, is it going to have any effects, and we did find that people liked it. They found it to be quite interesting, and we were able to find some effects on pre-sleep arousal and also self-reported sleep as reported on sleep diaries. So what we want to do is then take it to the next level. We refined it. We then packaged it into this 8-week program that looks a lot more like MBSR now. That's the current one that we call MBTI. And this is now an 8-week program where we integrate mindfulness meditation with some behavioral components that are usually used in cognitive behavior therapy for insomnia. The ones that we find most helpful are sleep restriction and stimulus control. Next slide, please. So just to give you a little more detail about MBTI, the program format that we use is that part of it is experiential, part of it has discussion, and part of it is a didactic. So it really mimics the pattern that they've been using in MBSR programs. And it is an 8-week program as well, I should say. So just to give you a sense of what we do, in the experiential component, this is roughly the first half of it, we usually do a quiet meditation and a movement meditation. And the quiet meditations, as you can see, are the body scan. We do breathing meditations and sitting meditations. And the movement meditation usually consists of either yoga, a walking meditation, and sometimes other forms of movement meditations like Qigong, and sometimes even bring in a little bit of Tai Chi. And then following the meditations, we have a period of inquiry or discussion where we have the group discuss different applications of mindfulness in their lives, different challenges that they've uncovered. And the idea is that there's a common element of suffering, and in this context, a common element of sleep disturbance and daytime consequences that come with insomnia. And then in the didactic part, what's a little bit different between what we do in MBTI and what's usually done in MBSR is that the didactic consists of behavioral strategies that are specifically aimed at improving sleep. I should say nocturnal sleep. So stimulus control and sleep restriction are two of the main components, behavioral components of CBT, as I said earlier. And so we integrate that into our program here. Now, one of the things that I'll note at the bottom there is that those behavioral strategies are participant-driven. So what we do is we give the participants the instructions for how to do stimulus control. So just in case you're not familiar with stimulus control, these are the instructions of only going to bed when you're sleepy, and if you go to bed and you're not sleepy, after about 15 or 20 minutes, to get out of bed and do something soothing and even relaxing until you regain that sensation of sleepiness, and only then should you go to bed. So it's those instructions of getting out of bed and then only going back to bed when you're sleepy. We give the participants these instructions and ask them to find ways to discover how they can apply that in their own situation. And sleep restriction is coming up with a schedule of going to bed and getting out of bed that is usually less than what they're currently doing. The idea behind this is to help to increase the sleep appetite or the sleep drive to help them fall asleep faster and stay asleep. And usually in cognitive behavior therapy, this is done prescriptively, where the therapist tells the participant what to do. In our program, we give the instructions to the participants and allow them to develop their own program. We do have a little bit of veto power, so in case they're not doing it correctly or they're not doing it in a way that we think is going to be helpful, we can try to guide them a little bit. The other piece of homework I should mention here is that we ask participants to do 30 minutes of formal meditation practice per day, 6 days per week. Next slide, please. So the other thing I should say about MBTI that sometimes gets misunderstood is that we're not trying to meditate patients to sleep. So this is not just another relaxation exercise. It's not a different form of progressive muscle relaxation. We actually encourage people to practice the meditation during the daytime when they're not in bed, because the idea is to try to become more aware and develop greater awareness. And it's through these meditations that it's an opportunity to cultivate awareness of thoughts, feelings, and physical sensations in the moment. So it's as they occur. And the reason we do this is because we want people to use mindfulness meditation to promote a greater awareness of mental and physical states, not to just fall asleep, so that they can really understand and learn what the process of falling asleep is like. For example, we're most likely to be sleeping when we feel sleepy. Right? That seems like a pretty simple concept, but people with insomnia often get sleepiness and fatigue confused. So they may lack energy, and because of that, they go to bed. or they may be frustrated with the day and they want to get away from the day, and so they go to bed. But neither of those situations are going to be optimal for helping you fall asleep. So what we're trying to do is get people to get greater awareness of where they are, both mentally and physically, so that when you're sleepy, you have a better chance of falling asleep. And you can answer this question of, is your mind and body ready for sleep, or are you just trying to get away from being awake? So that's really what we're trying to do with MBTI. Next slide, please. Okay, so now I want to shift to some of the research that we've been working on, and I'm calling this MBTI on trial. So we have a small-scale randomized clinical trial that we recently completed, and we're starting to look at the data. And this is actually, if you want more information about this, it's presented on clinicaltrials.gov, and the number there is, if you want to look it up. But I just want to give you a little bit of data and explain to you what we're looking at and some of our preliminary findings. I do want to emphasize that these are preliminary findings because it is some of the data is being written up in a manuscript that's currently under review. So it hasn't gone through peer review yet. So please note that these findings are preliminary. So anyways, the trial that we're doing, the primary aim of what we're doing is to obtain evidence for the efficacy of mindfulness-based therapies, and we're comparing it to a self-monitoring control. This is where people just are monitoring their sleep through sleep diaries. And the comparison is on both sleep and arousal for people with chronic insomnia. And the research questions we're really interested in answering are, first of all, are the mindfulness-based therapies, and we have both MBTI and MBSR in this trial, are they superior to just self-monitoring? And then the secondary research question is, are there relative benefits between MBTI versus MBSR? So I'm going to talk today about the first question. Next slide, please. Okay, so our participants, we had 54 people. Our inclusionary criteria were people who had psychophysiological insomnia. So psychophysiological insomnia comes from the ICSD-2, which is the International Classification for Sleep Disorders. It's a little bit different than the DSM or the ICD, which I think many of you might be familiar with who have a mental health background. But psychophysiological insomnia is very similar to primary insomnia. It's considered a subset for people who have elevated levels of arousal. So if you think back to the models that we talked about before, we wanted to find people who had those elevated levels of arousal because we felt that this intervention specifically targeted that arousal. Okay, and we recruited both men and women who were aged 21 years and older. And as you can see, our exclusionary criteria here, we were fairly strict. We did not have people who were on medications for sleep, who had unstable medical or psychiatric conditions, who had other types of sleep disorders. We also wanted to exclude people who had been in MBSR or CBT, which is cognitive behavior therapy for insomnia, within the past year. So it was a relatively squeaky clean sample we were looking at just as our first shot. Next slide, please. So our outcome measures, so again, we're mostly interested in pre-sleep arousal. So we use the PSAS, which is a scale for measuring pre-sleep arousal. And then on sleep diaries, we use total wake time, which is the time it took someone to fall asleep, so sleep onset latency, in addition to all the amount of time they were awake after sleep onset. So we wanted to basically get the total amount of time they're awake while they're in bed. Our clinical endpoints here are the Insomnia Severity Index, and we had different cutoffs that have been validated here for treatment remission and response. And then just to note, we did have secondary outcome measures of objective measures of sleep, so polysomnography we had and actigraphy. I'm not going to be presenting those data today, though. Next slide. And just to give you a sense here of our study design, so this is a 3-arm clinical trial. I think I mentioned before we had 54 people randomized. As you can see there, we have MBSR, and that's a standard MBSR there. And then we have MBTI here in the second arm. Both of those are 8 weeks. And then the main comparison here is, it says here waitlist. It's really self-monitoring. These people were monitoring their sleep for 8 weeks. And then after that, they actually got behavior therapy for insomnia. But I'm just going to talk about that first comparison there. And we did have follow-up at 3 months and 6 months after treatment. Okay, next slide, please. So just to go into the study design a little bit more, the MBSR arm, it was a standard MBSR. So again, for those of you who are familiar with this, it's the 8-session version. Each session is 2.5 hours. There is a 1-day, we call it an all-day retreat. It's really more like a 6-hour retreat. And these are all conducted in groups. The MBSR group actually was a heterogeneous group, so we threw our participants with insomnia in there with all sorts of other participants. So that group was a mixed group, and it was delivered by doctoral level instructors. One was actually an MD, one was a PhD psychologist, and they did not have any experience in sleep medicine. And at home, for homework, the participants had to practice 45 minutes of meditation for at least 6 days out of the week. So what we wanted to do there was just to try to get MBSR in the way that is normally done as close to it as possible. Okay. So MBTI, as I've described this before, it's 8 sessions, so it's matched on the amount of contact that they have. It was delivered by an instructor who is trained in behavioral sleep medicine and mindfulness meditation, so that was actually me. And a slight difference is the at-home practice. We had them practicing for about 30 to 45 minutes. I mean, we told them the minimum was 30, so most people didn't practice more than 30. 6 days per week. And then we also had behavioral recommendations for sleep restriction and stimulus control, as I described earlier. And as I mentioned, the self-monitoring is just 8 weeks of keeping sleep diaries. And it was, it's not an active treatment. It was monitored by the research staff, and there wasn't any structured contact unless we had to try to track them down to return their sleep diaries. Okay, next slide. Okay, so just to give you a sense here of the participants, I'm just going to give you the highlights here. So the average age was about 43 years old. As you can see with each of the conditions here, we had 19 people in the MBSR condition, 19 people in the MBTI, and 16 in the self-monitoring control. We had about 3/4 of the sample were female, which is a little bit high for people with insomnia, but when you consider the fact that people who gravitate towards mindfulness-based approaches and alternative medicine tend to be women, that's not terribly surprising. We had a relatively diverse sample, and I'd say it's fairly representative of the demographics here in Chicago. Pretty well-educated group, pretty low BMI because we did screen out people with sleep apnea, and you can see the distribution here of relationship and marital status. Next slide, please. Okay, so just to show you some of the data here, I'm really just going to be presenting the averages just to give you a sense of how things went. So this first one is on our pre-sleep arousal scale. This is a total score, and the way to look at this is that the higher the score, the higher the level of arousal. So what we're looking for is a decrease in arousal. And as you can see here with the different groups, first of all, to point out this self-monitoring. So this is the control group. That's the orange group. They were pretty flat, as you might imagine, from baseline to post-treatment. Okay, if you look at the two mindfulness-based groups, so both MBSR and MBTI showed a nice decrease there from their baseline to post-treatment. And for the most part, those gains were maintained. It looked like the MBTI group maintained the decrease in pre-sleep arousal a little bit better when you move from post-treatment to 6 months, whereas the MBSR group started regressing a little bit there, especially at the 6 month. Okay, so this at least shows evidence that the mindfulness-based groups did decrease pre-sleep arousal as we hypothesized. Next slide, please. Okay, so this is sleep diary data, and again, our main outcome was total wake time, so this is the time it took them to fall asleep and also the amount of time they were awake in the middle of the night. Again, just to point out the orange group, the control group, self-monitoring didn't change, as you might expect, between baseline and post-treatment. And then the meditation groups, both MBSR and MBTI, showed a pretty significant drop there of about 40 minutes from baseline to post-treatment. And again, these improvements were continued in the 3 and 6 month follow-up. That baseline, it looks like there's a difference there between the meditation groups and the self-monitoring groups. It actually wasn't statistically significant, but there was a little bit of a difference there. But we did find an interaction here that supports that the meditation groups do significantly reduce total wake time from baseline to post-treatment compared to the self-monitoring group. Okay, next slide, please. So now we go into our clinical endpoints here. So if you're looking at treatment remission, and we're defining treatment remission as a change the ISI total score less than 8 at each time point. Okay, so at post-treatment, this is the proportion of each group that had an ISI score. This is the Insomnia Severity Index score less than 8. So that's considered people who have remitted. As you can see in post-treatment, there was, I think, just one person in the self-monitoring group that was in remission. And in both the MBSR and MBTI group, we're above 30%, a little bit higher there for MBSR at post-treatment. And then when you move to 3 and 6 months, so this is just with the MBSR and MBTI groups, they hover around 40%. The MBTI group increases a little bit there, up to 50% at 6 months. But it shows a relatively stable treatment remission there, even in the follow-up time. Next slide, please. Okay, so this is treatment response. So for this one, treatment response is measured as a reduction in the Insomnia Severity Index with a total score greater than 7 from baseline. So in other words, there is a drop in the Insomnia Severity Index from baseline of at least 7 points. Okay, so here you see that the MBSR group is relatively stable in terms of response to treatment, about 40% at post-treatment and up through 6 months. The MBTI group grows. They start off at 60% and goes up to 78%. So this actually isn't statistically different. The difference is not statistically significant, but if you just look at the pattern, it does seem to favor MBTI. So at 6 months, you're talking about, I think it's 78% compared to about 42% there between MBTI and MBSR. So it certainly looks promising and seems like it's in favor for MBTI. Next slide. Okay, so what have we learned then from this? Well, first of all, I think there's evidence for efficacy. So the mindfulness-based therapy significantly reduced pre-sleep arousal and total wait time, so our 2 primary outcome measures, compared to the self-monitoring condition. In terms of clinical significance, as we talked about, the remission rates for both MBSR and MBTI were between about 35 to 50%. So about a third to half the people were in remission. And then in terms of response rate, it really tends to favor MBTI, which is up to 78% at 6-month follow-up, compared to the MBSR group, which was around 40% from post-treatment up through the 6-month follow-up. But in terms of statistically significant differences, we weren't able to find anything between MBTI versus MBSR. Next slide, please. So, of course, our study isn't without limitations. Some of the limitations I'll note here, it is a relatively small-scale randomized clinical trial. We had 54 people in this in our sample here, so it's still a little bit early, but I think the data is promising. Other things to note about the self-monitoring condition, it was not an active treatment, so we couldn't control for things such as treatment expectations, therapist contact, other non-specifics that might be related to group treatment. So I think those are still important things to keep in mind when you're considering the limitations of our control condition. And the other thing is, this was a pretty small-scale project, so we only had limited treatment providers. This, of course, allows for the possibility of investigator bias. Our therapists and participants weren't blinded. Both groups knew what they were getting themselves into. So there could be the potential of, wanting to please in terms of their rating. Okay. Next slide, please. So in terms of future considerations, where might we go with this? I think at least with the data we have here, it shows that mindfulness-based therapies are viable treatment options for individuals with chronic insomnia. I think it deserves to be in the conversation at this point. I think it might be a little bit too early to say which one of these is better. Is it MBTI versus MBSR? I think some of the data favors MBTI, but since this was a small-scale study, it might be too early to draw that conclusion. And also, we don't really know how it compares to other things like cognitive behavior therapy for insomnia. So we really do need some larger-scale randomized clinical trials to provide what I would consider to be more confirmatory evidence. I think this is a good starting point, but I think we do need some more work in this area. And then I think something to be discussed is, well, where do these mindfulness-based therapies fit in? Especially since we have CBT for insomnia, where would we see this fitting in? And my thought is that if you look at something like a stepped care model, then something like mindfulness meditation, since it's MBSR and MBCT are already being delivered, then we can take advantage of these programs, and people with insomnia can go to those, because one of the limitations of CBT for insomnia is a lack of providers. Right now there's only about 250 people who are certified in behavioral sleep medicine that really have the credentials to do CBT for insomnia. So I think in part it can expand the delivery of empirically based treatments for insomnia. So I think it could complement and not necessarily be a competitor to CBT for insomnia. And finally, I owe a great deal of gratitude towards people who have helped me. I have a great team. I'm very lucky to have funding from the NIH to help support this program of research. I have fantastic mentors. Couldn't do this work without them, and I wouldn't be here if it wasn't for their generous time and support and mentorship. So James Wyatt, Rachel Manber, Zindel Siegel, Shauna Shapiro, all of these are very instrumental in my development as well as the development of the research project. Yingling Xia, who is our statistician, also has been very helpful, along with our medical advisor, Dr. Chrysostomo, and then our research staff, our project coordinators, as well as our MBSR teachers. And so I'll leave you with this, which I think is kind of a funny cartoon here for not me much shut off the brain, but I really appreciate your time, and thank you for spending your evening with me. I hope this was informative.
Well, I want to thank you so much, Dr. Ong, for an excellent presentation, and already in the chat area, for those of you that are participating live, do have some questions to follow up, since they really want to pursue MBTI. So I want to turn it briefly over to Heather Butts, our producer from Learn for Life Consulting. So Heather, welcome back, and do you have any questions that you'd like to share?
Yes, thank you so much, Ed. So one overall question, which seems to go with the theme of the topic, has to do with lack of providers. You mentioned there are 200 providers approximately who are able to do CBT for insomnia. Maybe you could talk a little bit, Dr. Ong, about training additional individuals to do this kind of work, and what you think it would take in order to get more people to have the certifications to be able to treat this population of individuals.
Yeah, so I mean, right now there isn't really anything formally available for MBTI. I think there is a lot of training available for MBSR. I know at the Center for Mindfulness, which is at University of Massachusetts Medical Center. I think it's in Worcester, Massachusetts. They do offer training there. I know that in the past, John Kabat-Zinn and Saki Santorelli have offered training. These training retreats in both California and New York. I have seen other workshops and trainings available at different conferences. So, I mean, I think right now, one way people who are interested could get training is to get training through MBSR or even MBCT. I know Zindel Siegel also offers different training workshops and retreats in MBCT. And so that way, at least, you can people can get the core skills of mindfulness-based approaches. And there's different schools of thought on this, but an important part of that, of doing this work and teaching mindfulness-based approaches, is to have one's own practice of meditation. So, getting that established, I think, is helpful, and will also enable you, I think, a provider to kind of learn from within and be able to deliver this really from a place of mindfulness and acceptance and compassion. So, what I would say at this point is probably to start general, and then, hopefully as we go along and we get some of our work published, we'll be able to be in a position to offer training for this. But I'd say right now there's nothing really formal for MBTI.
Okay. Ed, I'm going to hand it back over to you because I think you have a couple of questions as well.
Thank you so much, Heather. So for those of you that are listening to the live webinar, and those of you that will be listening to the webinar recording via YouTube, if you have any questions for Dr. Ong in the future, you are welcome to email us at info@mindbodymedicinenetwork.com, and we will refer any of your questions to Dr. Ong. I know there were some questions about the presentation being available as well as the protocol, and as Dr. Ong mentioned, that will be forthcoming at a future date, but by all means, please email us and we can email you back in the future, and all of you will be receiving a recording of this webinar within the week. So there is another question, really our last question, because we have run out of time, and for those of you that want to ask more, please email us at info@mindbodymedicinenetwork.com. But question that has been asked is, Dr. Ong, is what have you been found from participants to be the most helpful aspect of MBTI? What do they seem to resonate most with?
That's a good question. I mean, when I think back to just what people have told me, and oftentimes we conduct these exit interviews when they at the end point of our study. I think a lot of them have found that they are able to have a different relationship with their sleep, like they think about it differently. A lot of them will say when they first came into the program, their mindset and attitude was, oh, if I can only get better sleep, the rest of my life will get better. And I think having gone through it, well, first of all, they say it's not what they thought, that it's actually quite a bit of work, and they thought they were going to just get a relaxation program. But having put in that work, I think they start to realize that there are different ways to see the problem and see what insomnia is. And so, what they've learned is that they can see it in a different way. It doesn't have to they're not as absorbed with the problem. It doesn't have to kind of ruin their whole life, that they are actually able to have not perfect sleep, but still be able to do the things that they want to do in their life. And so I guess in a lot of ways they've learned that they actually have more control over the situation than they originally thought.
Excellent. Well, thank you so much, Dr. Ong, and wanted to ask you before we conclude our presentation if there are any closing remarks that you would like to make.
Well, just to thank you, Ed, and Heather, for this opportunity. It's really an honor to be able to share this work with everyone, and again, just to thank the audience for their attention.
That's wonderful, and I do want to thank everyone who have participated in our live webinar. The chat room is buzzing with lots of helpful information from our participants, and anything that you would like to follow up with, don't hesitate, again, to email us at info@mindbodymedicinenetwork.com, and we will get your questions answered. So thank you, everyone, for joining us with using mindfulness and acceptance-based approaches for insomnia with Jason Ong, PhD. Thank you. And this concludes our webinar.